I'd like for you guys to welcome Dale Wood. Dale is the Vice President and for System Improvement and Chief Quality Officer for Charleston Area Medical Center. Dale's has a significant experience in healthcare operations, quality process performance improvement, financial planning, analysis, and strategic operational planning. He has a degree from LSU and from Duke, an MBA from LSU and an MHA from Duke, so he's got the SEC and the ACC covered. So it should please most folks here. Today, Dale's going to talk to us about developing a patient-centered approach using technology. So, Dale, welcome.
We're talking about these three hospitals. We've got the Memorial Hospital dominantly on trauma and patients coming there for it. And then the third is the Women and Children's Hospital. We have other hospitals and entities in the system, but these are the three that I'm going to be talking about today. So one of the things I always like to do when I come to a conference is to identify what kind of results are people getting from their initiatives and how relevant is it to what it is that we want to achieve in our organization. So that's what I'm going to try to give to you today. One of the things that I've learned in working in improvement for many years is that you have to take things in context. If I just got up here and told you about a technology or a tool that we use to help us improve patient satisfaction, I don't think it would be that helpful to you without understanding a little bit of the context in which that is developed. I've learned that in order to make any significant change, you have to focus on three areas. One has to do with the larger field dynamics that play in any organization, your climate, culture, those kind of things. Formal structures is what most people think of when they think about change. That would be an example. That would be the technology tool, policies, procedures, buildings, facilities, equipment. And then the third has to do with face-to-face routines and how people think about themselves and their role in the organization. So as a nurse, do I think it's my responsibility to provide patient satisfaction or to deliver technical care? A lot of aspects to face-to-face routines, and all of those have to be considered, those three large areas, the field dynamics, face-to-face routines, and the formal structures. I just thought I'd put up here real quickly something showing you the value-based purchasing comparison. This is looking at the difference between our baseline and the result period. You see the scores in red are for the General Hospital and the blue are the Memorial Hospital. Significant improvement in most areas in the time frames that we were working on here. Continue to see improvements in those outcomes. I wanted to let you know that we're focused on improvement. It's a big Six Sigma lean improvement methodology at play at CAMC. We have 7 master black belts and 1 black belt full-time that work in this area. And so I want you to have a sense of that because it's all connected with the ability to make improvement and satisfaction for us. I threw up some examples of the cumulative financial impact on the organization since we started Six Sigma. When we first started it, we brought GE in to develop capabilities, but have been independent for quite a long period of time. I think we've had a pretty significant financial impact, and you can see just in the last couple of years it's accelerated out of need. I didn't come to talk about that, but wanted you to see some sense of it. As it relates to lean, you see some of the ways that we've been able to reduce the FTEs has to do with the ability to do standardized work and eliminate waste. It's still a long way from being common part of our language, but a large number of people are familiar with it. We've seen improvement on multiple facets. That's the point I'm trying to let you know right here before I get into the satisfaction. Looking at mortality rate over time, observed to expected. Mortality continues to go down, the OD ratio. Surviving sepsis campaign, significant improvement there. Changing the baseline mortality down to from 37% down to 27% for the sepsis patients. This is looking at one of the interventions for mortality. Our OD ratio right now is at 0.6 for all patients. That's including Medicare, everyone else. The sepsis and The medical emergency team, or rapid response team, as IHI called it, when they worked on this stuff, has had a big impact, reducing incidents of neonatal nosocomial infections. I didn't come to talk about any of these improvements. I just want you to get a sense of the magnitude of the impact and the infrastructure that exists in order to deliver improvements in the areas that I'm going to be talking about around satisfaction. So, saw significant improvement in cardiovascular surgery skip evidence-based care indicators. Most of you, I'm sure, are looking at these kind of things, Six Sigma and Lean, reducing waste, looking at our Gapter waste and saving $1.9 million annually associated with that. That goes hand in hand with being a very large, having one of the hospitals' very large heart program. And then IV waste reduction, continuing to see improvement in that area, focus. And improving the charge capture of hospital-based physician hospitalists. Now, we've grown a big hospitalist program in the last 6 years. We currently have about 23 hospitalists, sometimes as many as 26. And what we found out was we weren't doing very good at capturing the charges for the work they were doing, and so using the concepts of Lean and Six Sigma, we were able to improve that. Now, here's just a few examples that I pulled out that have to do with the dollar savings associated with those Lean Six Sigma initiatives. Again,